Moving on to the same spectrum, we have Dr. Anirudh Agarwal, who's moved to Abu Dhabi, but we still consider him part of PGI. He will be talking about looks like AMD, but is not AMD. And this is very important because many a times you would see that you have been treating a patient as AMD, and then patient goes to a higher center and he's told, oh, this is not AMD. Why have you been given injections? So it's very important to know the mimicals of AMD. Over to you, Ani.
Very good morning, and thank you to Dr. Vishali ma'am for making me part of this IC year after year. And these patients, really, I'm going to show you 5 cases of AMD, and these are all from PGI. And what I'm going to show you is the important question which Dr. Vishali asked. When you have a patient with AMD, to my mind, I think there are 2 points which we need to understand. One is whether you inject or not. So whether there is a neovascular process or not. And second, if there is fluid, what do you do with the fluid to protect the photoreceptor damage? So this is a patient who is a 73-year-old male, has previous injections Lucentis elsewhere, and comes with a visual acuity which is low in the left eye. You can see that there are some yellowish lesions even in the right eye. So you have deep lesions and you have hemorrhage in the left eye right in the center. Now, if you look at the OCT of this patient, the OCT clearly shows you that there is a membrane and there is fluid. And of course, there is fluid even in the right eye. So to our minds, without thinking much, we could go ahead and inject. But if you really look carefully into this problem, going back to the fundus photograph, so you have some neovascular lesion, a grayish membrane, which we classically call as choroidal neovascularization, but you don't observe a single drusen in either eye. And this is one very important finding that you should be looking for in all your AMD cases. Now, in general, we like to classify our CNV lesions into type 1 and 2 or mixed. This is a classic case of type 2. And remember, in all classic cases of type 2, CNV where you have subretinal membrane, you must always consider a secondary cause. So if you look at this patient, this is the fluorescein. It's not much contributory. There is leakage. This is because of the choroidal neovascularization. So the diagnosis, of course, like I said, will be again very simple, bilateral CNV in wet AMD. But what does the ICG show here? The ICG shows you that there is hypoperfusion in the macula in both the eyes. And you have more lesions. You have satellite lesions around the central area. So this is not really an AMD. And these lesions were actually highly suspicious of choroidal granuloma. And this is where your ICG comes to, a central role in managing these patients. So this patient went on to get investigated with ACE, TB, CT scan. The chest CT was positive, quantiferon was positive, and this patient had a sputum culture which was positive for TB. So this patient was diagnosed with serpiginous choroiditis, choroidal granuloma, and this patient underwent the treatment with steroids, anti-TB, and this patient improved. So you can look at the follow-up images. And the anti-VEGF was, of course, it was given in the left eye for the CNV. But the most important aspect here is not to miss the primary diagnosis. Moving on to case 2. So this is a patient who's been diagnosed with wet AMD. She is elderly. She falls into the age group and has low visual acuity. But this is a more complex case. So with the background of PCV that you've heard from Simar and pachychoroid from Dr. Diksha, you can see that this patient has a combination of findings, and I'll dissect each finding in this image. So you see that there are certain lesions here. There is a hemorrhage, and there are some nodular lesions in the posterior pole, some orangish nodules in the posterior pole. Now, if you look at the combined fluorescein ICG, there's nothing much obvious. It's not very in your face. You see some leakage hyperfluorescence on both. But if you look carefully, you find that there is kind of a vascular anastomosis. There is a kind of a vascular anastomosis which is happening possibly in this area. And you have a bunch of hyperfluorescent lesions over here. So we're looking at this particular area here, and this is the area where you had the bunch of the PCV, kind of a polypoidal lesion over here at the bottom. And you had this kind of anastomosis in the superior part of the macula. This is the OCT of the patient. Now, the OCT passing through the bottom of the lesion where we suspected polyps, you see the peaked PED, the hunch, which is classic of PCV, and a polyp. So definitely there is no doubt that this patient has polyp in the eye. These are further scans from the bottom lesion. The bottom lesion, which is hyperfluorescent, you see a tall peak PD, you have the double layer sign. All of these are classic of PCV. So PCV forms a very important diagnostic, a differential of AMD. And I'll just go back to the superior lesion. The superior lesion is actually a RAP lesion over here that you can see. So many of these patients can present with a combination of findings. When you have a pachychoroid, they can have a combination of findings, and these present a very important differential diagnosis of AMD. Moving forward, so I'm going to skip this because this has been covered. You can now diagnose PCV without ICG. You don't need ICG. You have multiple signs on OCT by which you can diagnose PCV. The third case is this of a male patient who again has been diagnosed with bilateral AMD, and you can see here that there is some fluid in the center in the left eye, and you have separation or double layer sign sort of in the macula. But what you see also is a pachychoroid, and the choroid is focally quite thick in the nasal part of the macula. So this is the ICG. Again, you have this hyperfluorescence. And this is what we classically call as PNV, pachychoroid neovasculopathy. Again, going back to the fundus photograph, this patient does not have any drusen or any other feature of AMD. And this is when you should look at the other differentials. When you have a pachychoroid, in general, eyes with AMD will have a thinner choroid. But if you have a pachychoroid spectrum, look at other possibilities and look at PNV, I think, which is often under recognized in our clinics. The importance of doing that is that these patients can have an overlap. So patients with PNV can progress to develop PCV. They can have a concomitant CSC. It's a whole story once you diagnose pachychoroid. Now this is another patient here who is complaining of decreased vision in both the eyes, and what's striking to me is the age. 50-year-old male, metamorphopsia both eyes. Do not be very prompt in diagnosing AMD in these patients. So you can see here you have multiple drusen. I've been saying drusen are important for diagnosing AMD. Now this patient has bilateral drusen. But the characteristic of drusen becomes very important. So if you look at the fluorescein and ICG, you have scattered multiple drusen, and this is a type of an early onset drusen. Now, the important thing of these patients with early onset drusen is that they are very bright on the fluorescein ICG, multiple, they are scattered throughout, and you can see that they could be bilateral. And sometimes if you look at the ICG, you might think that there is a large vessel going right in the center, and you think it's a pachychoroid. But these are all findings of early onset drusen. So as you can see on the OCT, you have this kind of cuticular drusen. These are mounds of drusen, and you also have fluid. Now what's important for us to recognize is that in these eyes, when you do an OCT angiography, you will not find a neovascular membrane many times. And what's the reason for this? The reason is that this fluid that you see is a non-neovascular fluid. It is not because of a choroidal neovascularization. Many of these eyes will have fluid, and this is possibly because of micro leakage. The drusen may be leaking, so we don't really know what's happening. But this is not a neovascular process. So before you start injecting, just hold on, do not inject. And I would say that just follow up these patients with OCT angiography periodically to make sure that what you're treating. So do not be very prompt in, again, treating with anti-VEGF. This patient came back with the same OCT without any change in the fluid 6 months from the initial follow-up without any treatment. Now, this is my last case. This is another patient with recent onset metamorphopsia only in the left eye. Now, you can see over here that there is definitely a lesion which is located in the center, and you have a hyperreflectivity right in the intraretinal area and separation causing a double layer sign. This is the fluorescein. Again, it shows you hyperfluorescence, not very contributory. It's showing some late leakage, but the autofluorescence becomes the most important in these patients. So with the autofluorescence image, you have the one spot diagnosis of adult onset vitelliform disease. So this is a vitelliform lesion which is located in the center. And again, going back to the OCT, just want to highlight this hyperreflectivity in the intraretinal area. So the hyperreflectivity in the intraretinal area, and sometimes these hyperreflectivity may migrate. It may be even present subretinally, and this is the clue to diagnose vitelliform disease. And of course, the autofluorescence gives you the diagnosis. So this is the patient actually followed up for so many years, 2012, 2017, did not receive a single anti-VEGF injection, progressed to atrophy. So remember, do not inject if you are suspecting a vitelliform disease. And so I'll just summarize. So PNV, PCV, they're the most important components of pachychoroid that you can confuse with AMD. Uveitis in some situations, early onset drusen, and vitelliform disease. Thank you so much. Thank you.
Thank you very much, Anirudh, for very clearly showing when not to inject and what all can mimic AMD. So, Mike, I think what you showed beautifully is the drusen. If you do not see, it may not be AMD. And secondly, not to confuse familial drusen with age-related drusen, because familial will be distributed all over the posterior pole, and on angiography they will lit up differently.
Right.
So yes, Saurabh, questions. We are welcoming all the questions, please.
Very nice cases, Anirudh.
Thank you.
I had a question. If you have a very high tense PD, at what point of time would you like to inject or observe these cases? Because often the CNVM is draped underlying that, and you can have an RP rip. So in those cases, what are the indications when you will go for treatment, and when will you observe these cases?
So if you have a tall PED without subretinal fluid, that becomes a dicey situation. But if it is subfoveal, I would be more inclined to treatment actually. And I think with ILIA, the chances of RIP are quite less. Usually ILIA will decrease the height of PED. So if I feel that the PED is quite high with subjective symptoms of metamorphopsia or decrease in vision, I would be inclined to treatment. So and of course, if you find fluid, then there is no doubt that you will inject.
Any steps you'll take to prevent this RP rip in your experience? Do you do anything different in these cases? Would you do a paracentesis? Would you give some Diamox? Or
It
because
doesn't.
it's commonly
Yeah.
believed that a sudden increase in IOP in these cases can lead to a rip. So
You could do half injection of ILIA. You could do a half dose rather than full dose. But I think paracentesis probably will not help. So I think the insult is when you do the injection itself. So some people actually do half injection ILIA, half dose.
Thank you.
Yes, the next question.
Sir, as you mentioned in the adult onset vitelliform disease, it
Yeah.
should be the hyper reflectivity should be intraretinal for the
No, it
diagnostic.
could migrate. It could migrate. The hyperreflectivity could be intraretinal, or it could migrate and it could be actually subretinal by the time you see the
So
patient.
usually, like what all cases till now I've seen all the times it's subretinal.
Yes.
Only
Yes,
so-
this patient actually came very early. So he presented quite early with metamorphopsia, and he had the intraretinal, but it can migrate, like I said, slowly. Eventually, it goes subretinally. So the test to rely on is autofluorescence.
yes, and it could be like parafoveal also. It's like all the time.
Yes, it could be parafoveal. It could be diffusely distributed all over the fundus. It could mimic retinitis. So you could confuse, and you feel that this is a scattered vitelliform disease. But they all belong to a spectrum of vitelliform dystrophies.
Thank you, sir.
Sure.
So the
Thank-
early drusen that you showed, would you call that a non-neovascular exudative AMD, or is it a separate entity?
So, about for this patient, I had a discussion with Giuseppe Kirkis, and we looked at the OCT angiography quite thoroughly. We did not find any evidence of neovascularization. So, he said that we believe that this is a microvascularization, micro neovascularization, which is probably not apparent on OCTA, or this is a leakage from the drusen itself. The drusen is supposed to leak or exude. I don't know how it does that, but this is all hypothesis, I think.
Lovely cases, really lovely. I
Thank
just
you.
wanted to answer your comment on when you have multifocal VMD lesions,
Yes.
look for malignancies. They are associated with malignancies. And classically, VMD will start in that space. That is, how do you differentiate the drusen from VMD other than the hyperautofluorescence, which is very different, is the location. So it has to be above the RPE for it to be VMD. But multifocals, please look for malignancies. Thank you.
So I think not everyone could hear that. The comment was that drusen would be, in a particular location, and the vitelliform deposits would be above the RP or below.
Just one thing I want to ask Dr. Anirudh.
Yes.
See, you are told that high peaked or tall PEDs, better, you are in treating with ILIA. What is your take on treating with brolucizumab on these PEDs? Whether, because brolucizumab is meant to giving best results in patients with PEDs,
Yes.
especially.
I like brolucizumab a lot. With the anatomical response is quite good. It has very good flattening effect. But with faricimab, brolucizumab, and ILIA, you see flattening effect with all of them. But BU, I think like brolucizumab is quite effective in these patients. With
So-
PCV, it is one of my first line agents actually.
So in this situation, in a case with huge PED, will you prefer ILIA or brolucizumab? Which will be your preferred choice?
I don't have a preference. I don't have enough patients to answer that actually.
I have seen drips immediately with after brolucizumab. That's why I am just.
Okay.
I think Mohit is going to show some of these
you,
cases
ma'am.
with
Thank you,
PED tall. Yes. Another question?
Dr. Anirudh,
Yes.
about early onset drusen, do you need to rule out any kidney disorders,
Do we need to rule out?
renal disorders,
Renal
disorders.
complement glomerular
Early
nephritis?
onset drusen, do they have
Yes.
any association? with
You can, but I have never seen one patient, so I don't have a patient with concomitant renal disease, but I'm sure there are situations where there are associations.
I think we did see quite a. You have one last question?
Yeah,
Sure.
Again, a comment on his question. You can have diffuse drusen, which are associated with acute glomerular nephritis, but the phenotype is different than the early onset, the basilar type that you showed.
I
They
had
are
one
more-
patient with IgA nephropathy with
Yes,
pseudodrusen.
that's right.
SLE can present with pseudodrusen.
So they have these clumps and big and they're peripheral, but they're different than the starry appearance that you showed.
Right.
So they can be associated.
Thank you. Thank you, Anirudh.